Alright, hi everyone. So today we will be talking about a very important organ in the human body. But before then, if you haven't subscribed to my YouTube channel, I want you to do that right away so that you will be among the first set of people to get my YouTube videos each time I post them. Thank you as you do that. Alright, so today we'll be talking about a very important organ in the human body, the thoracoabdominal diaphragm. It is very important due to the function that it performs in relation to respiration. Okay, so above here we have outlines that can help you to tackle this topic each time you see it, maybe in an exam or in an essay. You were asked to write an essay about it. So we have the outline, introduction, we have the diagram, the function, the parts, the origin, shapes and resemblances, the crura, the ligaments, surface and relations, openings, the nerve supply, arterial supply, lymphatic drainage, the actions and the clinical correlations. So let's start. By way of introduction, the diaphragm is a dome-shaped fibromuscular sheet that separates the thoracic cavity and the abdominal cavity. So it is a fibromuscular sheet and it lies between the thoracic cavity above and the abdominal cavity below. Now, diagram. You can use any of these diagrams here. This is an elevated. This is a diagram of the diaphragm that is showing an elevated diaphragm. So it is elevated anteriorly with the help of pin structures here. Okay, so this is the inferior surface of the diaphragm, and here this diagram is showing the relations of the diaphragm. We will still talk about the relations when we get there. So what is the function of the diaphragm? The diaphragm is very important in that it is mainly involved in respiration. It is actively involved in inspiration and it is passively involved in expiration. So it is a muscle, it is an organ that helps in breathing. So that is the function of the diaphragm. The parts of the diaphragm, we are talking about the fourth outline right now. So what are the parts of the diaphragm? The diaphragm has two major parts. It has the central tendon and the peripheral muscular part. The central tendon is, as you can see on the board, this is the central tendon here, and these are the peripheral muscular parts. So the central tendon is a centrally located fibrous aspect or part of the diaphragm. It lies behind the xiphoid process of the thoracic wall. Okay, so the peripheral muscular part of the diaphragm, it arises as the inner layer of the muscles of the body wall. It arises in continuity with the transversus abdominis muscle within the costal margin. Okay, so the fibers of these peripheral muscles of the diaphragm, the fibers, they arch upwards. Let me show you. So using this diagram, this is the peripheral muscle of the diaphragm. This is just like a cross section of the diaphragm. So the muscles of the diaphragm arches upwards, as you can see, to form the dome shape at both sides. So this is the left side and this is the right side of the diaphragm. This is the left and this is the right. So the muscles, the fibers arches upwards, and then they descend forwards to insert into the central tendon. So the fibers of the peripheral muscular part of the diaphragm inserts into the central tendon. Okay, so the central tendon is trefoil in shape, and like I said, the muscles of the diaphragm, they insert into the central tendon. Alright, so we'll be going to the next point here, which is the origin. So the diaphragm has three major origins. It has the sternal origin, the costal origin, and the vertebral origin. So for the sternal origin, this refers to the two fleshy slits of the diaphragm, the anterior aspect of the diaphragm, originating from the posterior aspect of the xiphoid process. The costal origin of the diaphragm refers to the parts of the diaphragm at the left and the right side, the six fleshy slits originating from the posterior surfaces of the six lower ribs of the thoracic cage. So take note. And then we have the vertebral origin. This vertebral origin is simply referring to the left and the right crura and the 5 arcuate ligaments of the diaphragm. As you have on the board here, this is the right crura, the right crus, and this is the left crus. So, and then this is the lateral arcuate ligament. This is the medial arcuate ligament. Okay, so then what are the shapes and the resemblances of the diaphragm? The diaphragm can take an inverted J shape. This is an inverted J, where this long limb represents the crura originating from the upper lumbar vertebrae. So the crura, as it runs upwards from the vertebrae and enters into the diaphragm, and the long and the short lip here represents the part of the diaphragm that inserts to the posterior surface of the xiphoid process. So another shape the diaphragm can take, when you look at it from above, the diaphragm can have a kidney shape. And then another shape that diaphragm can also take is the shape, the central tendon here can take a trefoil shape. That is the shape of the central tendon. Alright, so we'll be going to the crura. We'll be talking about it proper right now. So the diaphragm has two crura, the left crus and the right crus. This is the right crus, like I said before, and this is the left crus. So for the right crus originates from the upper lumbar vertebrae. Let me show you. So this is supposed to be the vertebrae. As you can see, so the right crus originates from the anterolateral surface of the L1, L2, and L3 vertebrae, and also from their intervening intervertebral disc. So you have L1, L2, and L3 vertebra with their intervening intervertebral discs located around here. So then the left crus is arising from just L1 and L2 with their intervening intervertebral disc. Note from their anterior lateral surfaces, as you can see. So then we'll be talking about the ligaments. We'll be talking about the ligaments here. So we have the median arcuate ligament, as you can see at the top. It lies as the anterior border of the aortic orifice of the diaphragm. This median arcuate ligament is formed from the medial edge of the right crus and the medial edge of the left crus. The both of them, they rise upwards and then form the median arcuate ligament in front of the aorta. So The next we have the medial arcuate ligament. As you can see here, the medial arcuate ligament is the thickened upper margin of the psoas fascia. So the psoas fascia is a fascia that lines the psoas muscle. So assuming this is the psoas muscle here, the psoas muscle is located around here, the psoas fascia is covering it, then the thickened upper margin of this psoas fascia forms the medial arcuate ligament, whereas the lateral arcuate ligament is formed as the thickened upper margin of the fascia that lines or covers the quadratus lumborum muscle, that is the lumbar fascia. So this is the quadratus lumborum muscle here. The arrangement of these fibers must not necessarily be as it is. So I'm just using this to show the different muscles. Okay. Alright, so this is the thickening of the upper margin of the quadratus lumborum fascia. So this medial arcuate ligament runs from the body of L1 to L3 vertebrae and then inserts at the ridge on the anterior surface of the transverse process of L1 vertebrae, whereas the lateral arcuate ligament continues from that point, which is the ridge on the anterior surface of the L1 transverse process, and then continues to run and insert at the 12th costal rib. Okay, so the next here is the surfaces and the relations of the diaphragm, and at this we want to use this diagram here. So this is the right, this is the right and this is the left. Okay, this is the right and this is the left. So we have two surfaces of the diaphragm. We have the upper surface, which is known as the superior or thoracic surface of the diaphragm, and we have the inferior surface, also known as the diaphragmatic surface of the diaphragm. Okay, so for the superior surface of the diaphragm, the relations there includes the basis. As you can see, this is the base and this is also a base. The basis of the pleura, the right and the left pleura, covering the lungs, and also the pericardium of the heart. The pericardium is inseparably fused with the central tendon. Okay, because the both of them have the same embryological origin. So inferiorly, the diaphragm is related to the right lobe of the liver. This is the right lobe of the liver here, and then it is also related to the right kidney lying posteriorly to this liver, the right kidney, and to the right suprarenal gland. By the left here, the diaphragm is related to the left lobe of the liver, as you can see here, the fundus of the stomach. This is the fundus of the stomach, and the spleen. So this is the spleen, and then it's also related to the left kidney lying posteriorly. The left kidney is lying posteriorly, somewhere around here. Okay, so, and it is also related to the left suprarenal glands. The superior surface of the diaphragm is lined or enclosed by a fascia known as the endotracheal fascia, whereas the inferior surface of the diaphragm is lined by the diaphragmatic fascia. So next we will be talking about the openings in the diaphragm. Okay, that brings us to this point. The openings of the diaphragm are divided into two. So we have the major openings and the minor openings. For the major openings, there are just three. Then the minor openings, there are many of them, but we will mention all of them here. Then for these major openings, we have the vena cava opening, we have the esophageal opening, and we have the aortic opening. For the vena cava opening, this is the vena cava opening. It's at the level of T8. The esophageal opening is at the level of T10, and the aortic opening is at the level of T12. The aortic opening is at the level of the lower border of T12, while the esophageal and the vena cava opening are at the level of T10 and T8 body of the vertebrae. Okay, so for the esophageal opening, the medial the medial margin of this right cruise runs a bit upwards, some fibers from it runs upwards and then joins the left cruise here, okay, thereby forming a sling-like loop which has a pinch cork effect on the esophageal opening. So for the vena cava opening, it is located within the central tendon, and it lies between the anterior central leaflet of the central tendon and the right posterior leaflet of the central tendon. The central tendon has 3 leaflets: the anterior central leaflet, the right and left posterior leaflets. So the vena cava opening lies between the anterior central leaflet and the right posterior leaflet of the central tendon. It lies a little bit or slightly to the right of the median plane. The median plane is located somewhere here, so it is slightly to the right of it. The contents passing through the vena cava opening includes the inferior vena cava, okay, that drains from the abdomen and the lower limbs into the heart. The inferior vena cava and the right phrenic nerve. These are the 2 major contents that passes through this opening. Then for the esophageal opening, the contents passing through it includes the esophagus, the right and the left vagal trunks that supplies most of the viscerals, and the esophageal branches of the left gastric arteries. Okay, then for the aorta, the contents of the aortic opening are 3, and from the right to the left they include the azygos vein, the thoracic duct, and the aorta. So that is it about the major openings. The aorta, for the sake of note, the aortic opening is circular in shape, the esophageal opening is oval in shape, and the vena cava opening is quadrangular in shape. Yes. Okay, then we'll be going to the next openings, which are the minor openings. So one of them includes the space of Larry. I'll be drawing to show this. Yeah, so we have the space of Larry. This is the xiphoid process here, and this is the sternum. So somewhere around here we have the ribs. So somewhere around here we have the ribs. These are the costal cartilages, and these are the ribs. So the space of Larry is located between the xiphoid process of the thoracic cage and the 7th rib. Assume this is the 7th rib. So the content or the structure passing through the space of Larry is the superior epigastric vessels. It passes through. Okay. So we also have a slit between the 7th and the 8th rib. So this is the 8th rib here. So the 7th and the 8th rib there is a structure passing between them. This is the musculophrenic vessels, which is a terminal branch of the internal thoracic artery. Take note of the internal thoracic vessel. So between the intercostal, within the intercostal spaces, which is located between two ribs. Okay, so we have the intercostal vessels and nerves passing through them. Okay, then we also have another structure passing through a space that is located at the lateral arcuate, behind the lateral arcuate ligament. So a structure passes down here. This is the subcostal nerve. Somewhere around here we have the sympathetic trunk. So the sympathetic trunk passes below or on or beneath the medial arcuate ligament. Also, there are still structures that pierces the left crus and the right crus. The greater, the lesser, and least splanchnic nerves pierces the both crus, the right and the left. So each one pierces its corresponding side. So it pierces through the right and the left crus. Okay, so in addition to the left crus, in addition to the contents passing through the left crus, we also have the hemiazygous vein. It also passes through. And also the extraperitoneal lymph vessels also passes through the diaphragm to drain into the lymph nodes located at the thoracic or superior surface of the diaphragm. These lymph nodes include the anterior diaphragmatic, the posterior, the right and the left diaphragmatic lymph nodes. We will still talk about that when we get to the lymphatic drainage of the diaphragm. So next, we'll be talking about the nerve supply to the diaphragm. The diaphragm is supplied by the phrenic nerve, the right and the left phrenic nerve. So it is mainly supplied by C3. It is supplied by C3, C4, and C5 root fibers, with the C4 predominating. Okay, so the phrenic nerve gives both motor and sensory fibers to the diaphragm. The sensory fibers are supplied mainly to the central tendon, to the pleura and peritoneum. Okay, so the intercostal nerves also supply the diaphragm, the lower 5 intercostal nerves and the subcostal nerve. The lower 5 intercostal nerve supplies proprioceptive fibers to the diaphragm. So next we will be going to the arterial supply of the diaphragm. The arterial supply of the diaphragm includes: one, we have the superior epigastric arteries. The superior epigastric artery is a continuation, or should I say the terminal branch of the internal thoracic artery. We also have the superior phrenic and the inferior phrenic arteries. These two are the major arteries, okay, supplying the diaphragm. The superior phrenic artery is derived from the thoracic aorta, while the inferior phrenic artery is derived from the abdominal aorta, and the superior supplies the superior surface, while the inferior phrenic artery supplies the inferior surface of the diaphragm. Also, we have the pericardiophrenix artery. The pericardiophrenix artery is a branch of the internal thoracic artery, also known as the mammary artery. Of course, the mammary artery supplies the chest wall and the breast. So the pericardiophrenik artery is derived from the mammary artery. Okay, so we also have the musculophrenic artery. The musculophrenic artery, just like the superior epigastric artery, is also a branch of the internal thoracic artery. Also, we have the lower intercostal arteries and the subcostal artery, which also supplies the diaphragm. The lower 5 intercostal artery and subcostal artery are branches of the aorta. So next we'll be going to the lymphatic drainage of the diaphragm. So the lymphatic drainage, I mentioned them before, includes the anterior diaphragmatic lymph nodes, which is located posterior to the xiphoid process on the anterior aspect of the diaphragm. We have the posterior diaphragmatic lymph nodes draining, of course, the posterior aspect of the diaphragm. It's located around the aortic orifice. So we have the right diaphragmatic lymph nodes, which drains the right of the diaphragm, and it is located around the inferior vena cava opening. The left diaphragmatic lymph nodes located around the esophageal orifice. Then the next we'll be talking about the actions of the diaphragm. In the beginning of my lecture, I said I made mention of the function of the diaphragm, which is seen in respiration. I said the diaphragm is mainly involved in inspiration and passively involved in respiration. So one of the functions of the diaphragm is that when an individual takes in air, that is, inspires air, it causes increase in the thoracic volume, and of course leads to the contraction of the diaphragm and causes the depression or the descent of the diaphragm downwards. So this will as well lead to increase in intra-abdominal pressure. Increased intra-abdominal pressure helps in passage of effluent, like in someone who wants to vomit, during defecation or during parturition, and some other scenarios. So that is one of the functions of the diaphragm, one of the actions of the diaphragm. So the diaphragm also has effects on these openings. Just like the vena cava opening, the contraction of this diaphragm, will lead to the widening of this opening, and this will result to increase venous return to the heart. It also has effect on the esophageal orifice. It has a sphincteric effect on the esophageal orifice, and it has no effect on the aortic opening. This is because the aorta does not directly pass through the structure of the diaphragm. It simply lies behind the diaphragm, and it is anteriorly bordered by the median arcuate ligament. Okay, so still on the actions of the diaphragm, some of the actions of the diaphragm is also seen in abdominal straining for people who lift weights. One of the function of the diaphragm is the increased intra-abdominal pressure. When there is increased intra-abdominal pressure, it will help to maintain the state of the vertebra, preventing deflection, and thereby helping the weights lifters to lift the weight. Okay, so we'll be going to the clinical correlations of the diaphragm. One of the clinical correlation of the diaphragm that is very important is paralysis. Paralysis occurs due to the damage to the phrenic nerve that supplies the diaphragm. Remember, the phrenic nerve is composed of C3, C4, and C5 fibers, with the C4 predominating. So when there is damage to the nerve, maybe due to a problem from the root, that is from the cervical plexus, or maybe directly at the trunk or at the branch, okay, so this can result to phrenic nerve damage, and when the phrenic nerve is damaged, the diaphragm becomes paralyzed. If it is bilateral, it can be unilateral or bilateral. If it occurs bilateral, that is on the both sides of the diaphragm, it is a very serious condition because it can result to respiratory failure. Okay, so another clinical correlate of the diaphragm is seen in hiccups. Hiccups is an involuntary spasmodic contraction of the diaphragm that is accompanied by the closure of the glottis. So this normally occurs when an individual just finished eating a meal or drinking due to gastric irritation. So, but the pathological causes of hiccups includes uremia, diaphragmatic irritation, phrenic irritation, etc. So we also have diaphragmatic hernia. Diaphragmatic hernia can be congenital or acquired. If it is congenital, then it is due to the failure of fusion of the pleuroperitoneal membrane during embryogenesis. So when it fails to fuse, it results, as the person grows, it simply results to hernia in the diaphragm. Acquired diaphragmatic hernia can be hiatal hernia or sliding hernia. I'll be drawing them here to explain. For the hiatal hernia, what happens is that the gastroesophageal junction is seen forcing itself through the hiatus, through the esophageal hiatus, and of course this can result to a condition known as GERD, G-E-R-D, gastroesophageal reflux disease. Gastroesophageal reflux disease, if not corrected, can further progress, undergo metaplasia, and becomes Barrett and lead to Barrett's esophagus. Barrett's esophagus, if not resolved, can also progress, undergo dysplasia, and forms adenocarcinoma, and of course becomes a life-threatening condition to the individual affected. Okay, so for the hiatal hernia occurring in the diaphragm, we have something like this. So this is the esophagus, of course this is the stomach. So this is the diaphragm. So in this condition, instead of having something like this, in this condition what happens is that in the hiatal hernia, what simply happens is that the diaphragm so this is the gastroesophageal junction. It's seen the gastroesophageal junction, it's seen protruding through the hiatus, resulting to gastroesophageal reflux disease. So another thing that can now in the rolling type, what simply happens is that the gastroesophageal junction is not affected, but some part of the stomach is seen rolling upwards along with the esophagus. Let me show you.
Okay.
So this is the stomach, this is a part of the stomach rolling upwards is a part of the stomach that is rolling upwards. So at this point, what could happen is that the the esophagus can be compressed by this part of the stomach that is affected. So it can affect the passage or entry of food. Another thing that can happen to this part of the stomach is that it can lead to compression on the blood vessels supplying this part of the stomach, and of course, if the blood vessels are compromised for too long, it can result to necrosis. Okay, so that brings us to the end of this lecture. Thank you for listening, and once again, if you haven't subscribed, I want you to do that right away. Thank you for paying attention.